ম্যাডাম আমরা এখন লাইভে আছি, আমরা শুরু করতে পারি ম্যাডাম।
So good evening, friends and colleagues. It's indeed a great pleasure and privilege for me to welcome you today to our session on hypertension. Today, two things are unique. First of all, we have started having our sessions in the evening, and this is our first session that we're having at 8 p.m. And the second unique thing is that we have got two of our most respected sirs or teachers with us. And these teachers have been an inspiration for us since we were students ourselves. So it's really an honor and a privilege for us to welcome Professor Shafi Majumdar and Professor Lutfur-Rahman with us. Very respected teachers, very knowledgeable. And today I hope that they will be sharing their wealth of knowledge on hypertension with us. And actually hypertension is such a subject, it is so topical. And this is the bread and butter even when we pass our exams, right? Because when we start doing our private practice, hypertensive patients are the most common patients that we will have to deal with, and to understand the practicalities of treating these patients is also very important. Like Professor Rahiduzzaman was just now mentioning that he was dealing with a patient who is not economically solvent, and that's why he gave that patient tablets that the patient could afford. And that's such an important aspect of hypertension, to understand the patient and understand what would be best for our patients, not just to follow the guidelines blindly, but rather to intuitively know what is best for our patients. So today, I hope that we'll be learning such a lot from all our speakers and from the great teachers that we have today with us. So without further ado, I'll start our session today. And I would like to request our guests to say a few words. Professor Shafi Majumdar, I'll be extremely grateful if you could say a few words, and then I'll invite Professor Lutfur-Rahman to say a few words, and then we'll start our session.
Okay, thank you, Professor Fazila. It is my great pleasure and honor to be with you at this session. And as we know, the hypertension is very common problem all over the world. Around 20% of the people, adult persons of our country, they suffer from the hypertension. Though the definition of the hypertension changes because of the findings of the big trial, shows at which level the blood pressure should be maintained, beyond which there will be some complications due to the high blood pressure. So the definition changes, and also changes depending on the which guideline we are following. Anyway, I think the speakers should elaborate on the subjects, and I may remind the students to think over the subject very carefully. Not only the definition and the other things, also to think over the pathophysiology of the disease, so that we can choose the drug in the particular patient at their particular stage of the disease. With these words, and with the hope that our next few minutes will be having a very nice presentation on the hypertension. Thank you very much.
Thank you, sir. So I would now request Professor Lutfur-Rahman to say a few words for our students, and then we will start our program.
Okay, thank you very much, Professor Dr.S.M.Rahiduzzaman. I am feeling very proud to be present with you. And hypertension, as Professor Majumdar mentioned, that is a very important chapter. For the student, it is very important, and for the practitioners, it is also very important. So, and I have seen that there are 4 legend speakers and learned speakers. Definitely, they will explain their topics very clearly and elaborately and presentation. So, I will request you to start the program.
Thank you, sir. So our first speaker is Dr. Kolimuddin, and he is really a very hardworking. Thank you, sir. So without further ado, I will request Dr. Kolimuddin to start his presentation.
Thank you, Madam, for your kind introduction. Honorable, respected, honorable moderator, respected panelists, and learned audience. Assalamu alaikum. I am Dr. Muhammad Kolimuddin, presenting definition, classification, and pathogenesis of hypertension. The relationship between blood pressure and cardiovascular and renal events is continuous, making the distinction between normotension and hypertension based on cut-off BP values somewhat arbitrary. However, in practice, cut-off BP values are used for pragmatic reasons to simplify the diagnosis and decision about treatment. Hypertension is defined as at the level of blood pressure at which benefit of treatment either with lifestyle intervention or drugs unequivocally outweigh the risks of treatment as documented by clinical trial. This is based on evidence from multiple randomized control trials that treatment of patient with this BP value level is beneficial. Then hypertension is defined as office blood pressure value, office systolic blood pressure value equal or more than 140 millimeter mercury, and or diastolic blood pressure values equal or more than 90 millimeter mercury. What are the benefits of treatment of hypertension? Meta-analysis of randomized control trials, including several 100,000 patients, have shown that a 10 millimeter reduction in systolic blood pressure or a 5 millimeter reduction in diastolic blood pressure is associated with significant reductions in all major cardiovascular events by 20%, all-cause mortality by 10 to 15%, stroke by 35%, coronary events by 20%, and heart failure by 40%. According to 2013 National Guideline for Management of Hypertension in Bangladesh, BP level is categorized into 6 levels: optimal, pre-hypertension, stage 1 hypertension, stage 2 hypertension, stage 3 hypertension, and isolated systolic hypertension, which is almost similar to 2018 ESC or European Society Hypertension Guideline. According to 2018 ESC and ESH guidelines, blood pressure is categorized into 7 levels based on the basis of office blood pressure: optimal, normal, high normal, grade 1 and 2 and 3 hypertension, and isolated systolic hypertension. Optimal hypertension is defined as systolic blood pressure less than 120 and diastolic less than 80. And normal blood pressure level is 120 by 120 to 129 systolic blood pressure, and or diastolic blood pressure 80 to 84 millimeter mercury. And high normal blood pressure level is 130 to 139 millimeter mercury, and or diastolic blood pressure 85 to 89 millimeter mercury. And grade 1 hypertension is defined as systolic blood pressure 140 to 159 millimeter mercury, and or diastolic blood pressure level 90 to 90 millimeter mercury. Grade 2 hypertension 160 to 179 systolic blood pressure, and diastolic blood pressure 100 to 109 millimeter mercury. Grade 3 hypertension equal or more than 180 millimeter mercury, and or diastolic blood pressure equal or more than 110 millimeter mercury. And they also classified isolated systolic hypertension as systolic blood pressure equal or more than 140 millimeter mercury, and diastolic blood pressure below 90 millimeter mercury. According to ESC AHA guideline, hypertension guideline, which is published in 2017, they categorize blood pressure level on the basis of office blood pressure into 4 levels: normal, elevated, stage 1, and stage 2 hypertension. Normal blood pressure level is less than 120 millimeter mercury systolic, and diastolic less than 80 millimeter mercury. And elevated blood pressure is 120 to 129 millimeter mercury systolic blood pressure, and diastolic less than 80 millimeter mercury. And stage 1 hypertension is 130 to 139 millimeter mercury, or diastolic 80 to 89 millimeter mercury. Either systolic or diastolic blood pressure level designated as hypertension. And stage 2 hypertension, 140 or more than 140 millimeter mercury systolic blood pressure, and diastolic blood pressure 90 or more than 90 millimeter mercury. There is change in blood pressure classification JNC 7 to JNC 7, and comparison of 2017 hypertension guideline with JNC 7. Elevated blood pressure and stage 1 was classified as pre-hypertension under JNC 7, and stage 2 was classified as stage 1 under JNC 7 classification. There is comparison of systolic Comparison of blood pressure categories according to the ESC 2018 guidelines and AHA guideline 2017. The major difference concerns the change in blood pressure classification, which affect the prevalence of hypertension in the population. Now, prevalence of hypertension in America is 46%, which was initially 32%. However, the number of persons to treat with an antihypertensive medication should increase by only 2 to 3%, because most patients should receive a non-pharmacological treatment. In the ACC-AHA classification, there is no stage 3 hypertension and the concept of isolated systolic hypertension. A larger use of cut off out of office blood pressure measurement to diagnosis hypertension, as well as white coat and masked hypertension, and to monitor treatment. The greater credit given to non-pharmacological approaches, the lower blood pressure level to start treating hypertension with drugs in cardiovascular risk. The lower BP goals for treated hypertensive patient, now it is 130 to 130 by 80 in ACC, according to ACC-AHA guideline. Now, definition of hypertension out of office blood pressure level according to 2018 ESC guideline: ambulatory blood pressure level if daytime equal or more than 130 millimeter mercury systolic and or diastolic 85 or more than 85, it is considered as hypertension. And nighttime blood pressure systolic equal or more than 120 and or diastolic 70 or more than 70 is considered as hypertension. And 24 hours average blood pressure level if more than or equal to 130 millimeter mercury on and or 80 or more than 80 millimeter mercury is considered hypertension. And according to home blood pressure monitoring, if blood pressure systolic is more than 135 or more than 135 and or diastolic 85 or more than 85 is considered as hypertension. Now, classification of hypertension in children and adolescents. In 2000, according to 2016 European Society of Hypertension guideline, the age over more than 16 years and older are same as adult person, but up to 15 years, hypertension is defined as equal or more than 95 percentile of normal adult blood pressure level. Hypertension can be classified as primary hypertension or secondary hypertension. Primary hypertension or essential hypertension is defined when underlying cause of hypertension is not known. It accounts 90 to 95% of adult patients with hypertension. Secondary hypertension is defined as when high blood pressure as a result of other medical problems or medication. It accounts for 5 to 10% of adult patients with hypertension. Secondary hypertension should be suspected in younger patients less than 30 years of age with elevated BP. Commonest causes are renal parenchymal disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, drug or alcohol induced 2 to 4%, pheochromocytoma, Cushing syndrome, hypothyroidism or hyperthyroidism, coarctation of aorta, primary hyperparathyroidism, and congenital adrenal hyperplasia and acromegaly. There are frequently used medication and other substances that may cause elevated blood pressure: amphetamines, antidepressants, atypical antipsychotics like clozapine, olanzapine, caffeine, nasal decongestants, pseudoephedrine, herbal supplements, immunosuppressants like cyclosporine, oral contraceptives, non-steroidal anti-inflammatory drugs, recreational drugs, systemic corticosteroid, and angiogenesis inhibitors. There are several modified and fixed risk factors for development of hypertension. Modifiable risk factors are diet in high sodium and low potassium, alcohol, smoking, diabetes, high cholesterol, overweight, physical inactivity, unhealthy diet. And relative fixed risk factors are obstructive sleep apnea, male sex, low socioeconomic status, increased age, family history of hypertension, chronic kidney disease, low birth weight, premature birth, and psychosocial stress. Now, prevalence of hypertension. The overall prevalence of hypertension in adults is around 30 to 45% with a global age standardized prevalence of 24% and 20% in men and women respectively in 2025. The high prevalence of hypertension is consistent across the world, irrespective of economic status. In lower, middle, and higher income countries, hypertension becomes progressively more common with advancing age, with a prevalence of more than 60% in people aged over 60%. Prevalence of hypertension in Bangladesh. Probably the prevalence of hypertension was first reported in 1976 by National Professor Brigadier Abdul Malik, which was 1.1%. In 2012, published in Indian Heart Journal by Monwarul Islam and Safi Mujumdar Sir, and they showed in Bangladesh, approximately 20% of adult and 40 to 65% of elderly people suffer from hypertension. And recently, in 2020, published in Clinical Hypertension Journal by Choudhury et al., that evidence from a systemic review and meta-analysis showed the range of hypertension prevalences is from 1.1% to 70%. And the overall weighted pool prevalence of hypertension is 20%. So in Bangladesh, average prevalence of hypertension is 20%. Prevalence was observed higher in females in urban areas and in the people aged 60 and above 60 years age group. Overall, an increasing trend of hypertension was also observed. Pathogenesis of hypertension. The pathogenesis of hypertension is multifactorial and complex. Multiple factors modulate the blood pressure, including humoral mediators, vascular reactivity, circulating blood volume, vascular caliber, blood viscosity, cardiac output, blood vessel elasticity, and neural stimulation. A possible pathogenesis of essential hypertension has been proposed in with multiple factors, including genetic predisposition, excess dietary salt intake, and adrenergic tone may interact to produce hypertension. Although genetics appears to contribute, the exact mechanism underlying essential hypertension have not been established. Neural mechanism in pathogenesis of hypertension. Overactivity of the sympathetic nervous system may play a greater role in the initiation of primary hypertension than its progression. Central sympathetic activation can result from deactivation of inhibitory neural inputs, activation of excitatory neural inputs, or from circulating angiotensin II, which activates pools of excitatory brainstem neurons without the blood-brain barrier. Renal mechanism in hypertension. A fundamental abnormality in hypertension is an acquired or inherited defect in the kidneys' ability to excrete the excessive sodium load imposed by a modern diet high in salt. Renal sodium retention expands the plasma volume, increasing cardiac output and triggering autoregulatory response that increase systemic vascular resistance. Salt retention also augments the smooth muscle contraction produced by endogenous vasoconstrictors. Vascular mechanism. Alteration in the structure and function of small and large arteries are pivotal in the pathogenesis and progression of hypertension. In small arteries, there is hypertrophy, eutrophic hypertrophy, and there is in large arteries there is hypertrophic modulation, and there is lumen to media to lumen is increased in small vessel and large vessel, but medial thickness is not change in small vessel but change in large arteries. The endothelial lining of blood vessel is critical to vascular health and constitutes a major defense against hypertension. Dysfunctional endothelium displays impaired release of endothelium relaxing factors like nitric oxide and enhanced release of endothelium derived constricting, pro-inflammatory, pro-thrombotic, and growth factors. Hormonal mechanism. Activation of the renin-angiotensin-aldosterone system is one of the most important mechanisms contributing to endothelial cell dysfunction, vascular remodeling, and hypertension. Renin, a protease produced solely by the renal juxtamolecular cells, cleaves angiotensin to angiotensin 1, which is converted to angiotensin 2 by angiotensin converting enzyme. The interaction of angiotensin 2 with G protein coupled angiotensin 1 receptors activates numerous cellular processes that contribute to hypertension and accelerated hypertension in organ damage, including vasoconstriction, vascular inflammation, vascular remodeling, and production of aldosterone, the principal mineralocorticosteroid. Aldosterone, angiotensin 2, and prorenin activates multiple signaling pathways that cause damage, vascular health, and cause hypertension. Thank you for patient hearing.
ম্যাডাম শুনতে পাচ্ছি না ম্যাডাম। ম্যাডাম আনমিউট করতে হবে ম্যাডাম।
কানেকশনের সমস্যা মনে হচ্ছে আপনার, একটু কানেকশনটা যাচ্ছে আসছে।
নেটওয়ার্ক প্রবলেম নাকি, কোনো নেটওয়ার্ক প্রবলেম?
নেটওয়ার্ক না, মানে এই যে
নেটওয়ার্ক প্রবলেম।
অডিও,
ম্যাডাম কাইন্ডলি হেডফোনের লাইনটা ডিসকানেক্ট করে দেন ম্যাডাম।
হেডফোন লাইনটা ডিসকানেক্ট করে দিয়ে সরাসরি কথা বলেন, ওটি ভালো।
Hello, শোনা যায় না?
এবার শোনা যাচ্ছে।
আচ্ছা, I'm sorry.
এবার শোনা যাচ্ছে, হ্যাঁ।
জি সরি, আজকে আমার কম্পিউটারে অনেক গ্লিচ হচ্ছে। So thank you for a great presentation. So I would request our panel of experts to ask any questions to the first speaker. Lutfur sir, কিছু question আছে?
One question is that in 2000 guideline of International Society of Hypertension, the grading of hypertension is different. But Kolimuddin, you have not mentioned possibly that one.
Yes, sir. Yes.
Have you mentioned that?
2020.
Have I missed?
2020.
I have mentioned 2020.
2020.
Yes.
Possibly this
Yes,
is the latest.
2020 there is a new guideline.
Latest classification of the here there is normal blood pressure, high normal blood pressure, grade 1 hypertension and grade 2 hypertension. These are the four types of hypertension. These are the latest, that is 2020 classification made by International Society of Hypertension. Possibly it is, we have missed it.
Yes, actually it's correct. There is another guideline that was recently done by International Society of Hypertension. Actually, they have tried to manage between the AHA and SPC guideline and implement a practical approach. That was a separate National Society of Hypertension, ISH. But I think there is not much difference between the classification of International Society of Hypertension and American Society of American Heart Association classification. There is very mild, very subtle difference between the classification between these two groups.
So we will go to detailed discussion at the end of the session. I think we can move to our next speaker now. And our next speaker is Dr. Dhiman Bonik. And I welcome him because he was unwell these last few days. Can you hear me?
Yes, madam, I can hear you.
Yes, thank you. So Dhiman, welcome back. And we're really happy that you have recovered well from the last onslaught of COVID. So congratulations on your recovery, and we hope to learn from you. And thank you so much for, even though you were unwell, you took the trouble to prepare this presentation for us. We really appreciate it. Dr. Dhiman Bonik.
Thank you, madam, for the kind words. Respected moderators, respected panelists, teachers, colleagues, and friends. Today, my presentation is on diagnosis, clinical feature, complication of hypertension. Hypertension is, to me, where to end, where to begin. I don't know even. I started with, sorry, my slide is not moving.
স্যার আপনাকে আবার স্ক্রিন শেয়ার করতে হবে।
আবার স্ক্রিন শেয়ার করতে আমি বন্ধ করে দিব না?
বন্ধ, স্যার স্ক্রিন শেয়ার বন্ধ হয়ে গিয়েছে। আপনি শেয়ার স্ক্রিনে যান, যাওয়ার পরে আবার হচ্ছে স্লাইড শোতে, হ্যাঁ
আবার যাই না?
হ্যাঁ স্যার, এখন স্লাইড শোতে যান। ওকে, এখন স্যার স্লাইড মুভ করতে,
yes মুভ করছে, হ্যাঁ মুভ করছে। Respected moderators, panelists, teachers, colleagues, and friends, I want to start with a clinical scenario. 45 years male, coming from farm gate, waiting in the waiting room of a physician chamber, 3 minutes. and then he was called to attend the physician for consultation, and the blood pressure measured is 160 by 100. And next, the consultant reviewing the patient regarding his hypertension, but the patient is saying that he has no hypertension. He measured his blood pressure almost regularly, and his blood pressure is always normal. Then what is the next or what will be the next scenario of this presentation, this clinical condition? With this, I want to start. Dr. Kolim has stated that the office blood pressure is the blood pressure. It is the which is measured in a doctor's chamber or in hospital or in clinic. It is measured mainly by oscillometric semi-automatic sphygmomanometer preferred by maximum of our doctors. A consistent and significant systolic blood pressure difference between the two arms. At first time when the patient came to us, we should measure blood pressure in both the arms, and twice should be measured at an interval of 1 to 2 minutes. And if the measurement is more than 15 millimeter of mercury, then there is increased risk of cardiovascular risk, and most likely it is due to atheromatous vascular changes. Improper measurement of office blood pressure measuring, it can lead to inaccurate classification, overestimation of patient's true blood pressure, and unnecessary treatment. This is the classical. This slide shows the classical features of measuring blood pressure in a patient. In a patient, you can measure. I want to highlight some important things. You can measure blood pressure. You can measure blood pressure by lying or by sitting. If you want to measure blood pressure by sitting, you should follow some things should be evaluated, but some things should be strictly followed. Feet should be on the floor, and there should be back support, and there should be relaxation of 5 minutes before measurement. 30 minutes before measuring blood pressure, caffeine, exercise, and smoking should be avoided. Bladder should be emptied. Patient should not talk and the observer during measuring the blood pressure. Cloths over the arm of the measurement cuff should not be there, and the arm should be placed on the desk of the patient, and it should be at the level of the right atrium, and the cuff should be accurately sized. That is, the bladder inside the cuff should cover 80% of the arm, and not smaller or not larger. And there are available of 4 size cuff in almost all over the country. And blood pressure at the first time, I previously mentioned that it should be measured 2 times in both the arms, and two times in each arm at the interval of 1 to 2 minutes. And the larger measurement should be recorded, and it should be next time the measurement should be on that arm. The first of all, the palpatory method should be evaluated. The radial pulse is felt, and the cuff is inflated, and the blood pressure, when it is abolished, then it is elevated up to 20 to 30 millimeter of mercury. Then by auscultatory method, systolic and diastolic pressure should be evaluated. The first carrot cough sound should be the systolic pressure, and the fifth carrot cough sound, that is the almost the absent Korotkov sound is the diastolic pressure. And the two readings taken should be averaged and should be averaged, and it should be written which arm and where. There is a new term in the guideline. It is unattended office blood pressure measurement. It is that there will be you can come out from the white coat hypertension. In this scenario I gave mentioned for the patient, it might be a patient of white coat hypertension, that in presence of doctors the blood pressure is more, but in unattended blood pressure can be evaluated. Automated multiple BP readings in doctor's office improve their producibility of blood pressure measurement, and the patient seated alone and unobserved, the white coat can be substantially reduced or eliminated. That is that you come to your room, there is no medical personnel, the patient and one or two patient attendant, and the blood pressure will be measured by them, and this will be the unattended office blood pressure. Use of unattended office blood pressure measurement in a recent clinical trial, the SPRINT trial, generated controversy about its quantitative relationship to conventional office blood pressure measurement. Its feasibility in routine clinical practice has also been questioned. Conventional office blood pressure reading may be at least 5 to 15 millimeter mercury higher than the systolic blood pressure level obtained by unattended office blood pressure measurement. That is, unattended office blood pressure measurement is less than office blood pressure measurement. There is a term, then the question arises in this scenario of the patient, which as I mentioned earlier, that how will we evaluate whether the patient is hypertensive or not? That is, there is a new term which is known as home blood pressure monitoring. There are different guidelines in different groups of home. The average guideline is at least 3 days blood pressure should be monitored, at least 3 days, preferably for 6 to 7 consecutive days before each clinical visit. Blood pressure reading should be taken 2 times in a day, morning and in the evening, in a quiet room, 5 minutes at rest. 2 measurements should be taken, we have previously said, and at an interval of 1 minute apart. And compared to office blood pressure, home blood pressure provides more reproducible blood pressure data and in more closely related to HMOD, particularly left ventricular hypertrophy. HMOD is the new term in the new guidelines. It is hypertension mediated organ damage. It replaces the term target organ development. In previously JNC 7, it was taught TOD, and now it is hypertension mediated organ damage. Recent meta-analysis of few available prospective studies have further indicated that home blood pressure monitoring better predicts cardiovascular morbidity and mortality than office blood pressure measurement. This is the measurement details. I want to skip this slide. Another thing is that with this clinical scenario of this patient, we can go for an ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring is a process. The cuff is placed in the hand where blood pressure is more. The cuff is placed in that hand, and there is a machine fixed at the waist of the patient, and the machine is such readily placed that it measures blood pressure in the daytime 15 to 30 minutes interval, and at night it measures blood pressure at 1 to 2 hours interval. And after 24 hours, we see this measurement, all the measurement in a computer, and the average blood pressure is taken. In the daytime, if the patient is awake, a blood pressure of 135 equal or more than 135 and more than 85, the patient is hypertensive. At night time, systolic blood pressure of 120, and in some authors says it is 80, and some authors say it is 70. Is 120 by 80 in night time, the patient is hypertensive. And the mean blood pressure for the 24 hours, it is, if it is 130, but more than 130 by 80 ambulatory blood pressure, the patient is hypertensive. Ambulatory blood pressure monitoring is a better predictor of than home blood pressure monitoring of hypertension organ damage than office blood pressure. 24 hours Holter ambulatory monitoring mean has been consistently shown to have closer relationship with morbid and fatal events, and is a more sensitive risk predictor than office blood pressure of cardiovascular outcomes such as coronary comorbidities or fatal events and strokes. It is the advantage and the disadvantage of office and home blood pressure monitoring. Advantage is of ABPM is stronger prognostic evidence of ambulatory blood pressure monitoring, and home blood pressure monitoring is cheap and widely available. And other there is this patient I have previously mentioned that patient is this patient which we are I have seen give this scenario. It might be a patient of white coat hypertension. Regarding white coat hypertension, I have previously said in front of medical personnel blood pressure is raised, and in home blood pressure monitoring, ambulatory blood pressure monitoring, and in both the blood pressure is normal. It is white coat hypertension. Regarding white coat hypertension, it is very important is that 13% of the patient during the diagnosis of hypertension is in white coat hypertension. But when the patient is on treatment, that is, your patient is on treatment and he came to you for follow-up, and you find that the pressure is more, but the patient is said that his blood pressure is normal. When he measured the blood pressure in his home, in his follow-up to other person or in family members, that is about 32%. That is that the patient is taking drugs, but his blood pressure is not controlled. And the on treatment white coat hypertension is about 32%. It ranges from 25 to 46% among hypertensive subjects, and it is proved in different randomized trials. There is a term which is known as masked hypertension. Masked hypertension is just the blood pressure is normal when it comes to a medical personnel, and blood it is elevated in ambulatory or home blood pressure measurement. It is about 15% of the patient. Prevalence is more in male patient, young female, smokers, less physical activity, alcohol consumption, anxiety, job stress, obesity, diabetes, chronic kidney disease, family history of hypertension, and marked hypertension is associated with dyslipidemia and dysglycemia and others hypertension mediated organ damage. This is the screening detection of a patient with hypertension. If blood pressure is at that is 120 by 80, follow-up should be at it may be followed for 5 years interval. A normal normal blood pressure of 120 by 29, 80 to 85. It may be followed up with 3 years, and high normal blood pressure at least 1 year follow-up. That is, it is pre-hypertension 130 by 40 and 85 to 90. And if the patient is hypertensive, then repeat visit for control of blood pressure should be done. And this is the clinical indication of home blood pressure monitoring or ambulatory blood pressure monitoring. Important is condition in which white coat hypertension is more common, as previously mentioned. Condition in where masked hypertension is common. Postural or postprandial hypotension in untreated or treated patient. Patient is saying that after taking meal, his blood pressure is reduced. He have sweating and his blood pressure is reduced. Then you can evaluate the patient with an home or ambulatory blood pressure monitoring. Evaluation of a resistant hypertension, it can evaluate by ambulatory or home, and evaluation of blood pressure control in treated high risk patient. When there is considerable variability in office blood pressure monitoring, ambulatory or home blood pressure monitoring can be done. This is important of assessment of a nocturnal blood pressure values and dipping status. That is, there is a suspicion that at night the blood pressure falls during sleep, in sleep apnea, in CKD patient, diabetes, endocrine hypertension, and autonomic dysfunction. This condition, in this such condition, this it can be evaluated with ambulatory or home blood pressure monitoring. With this, the terms, how to confirm the diagnosis of hypertension. The number one is very important. BP can be highly variable. The diagnosis of hypertension should not be based on a single set of blood pressure reading. In a single office set, in two condition, in a single setting, blood pressure should be said this patient is hypertensive. It is if the blood pressure is in grade 3 hypertension. That is, grade 3 hypertension is that in ESC guideline, it is systolic blood pressure equal or more than 180 and diastolic blood pressure equal or more than 110. And there is clinical evidence of HMOD, that is hypertension mediated organ damage, that is hypertensive retinopathy, exudate hemorrhage, there is LBH in ECG, and vascular and renal damage. For all others, repeat blood pressure measurement at repeat office visits have been a long-standing strategy to confirm a persistent elevation of blood pressure. For the classification of hypertensive status of the patient and in clinical practice and different randomized trial. A grade 2 hypertension patient, that is a blood pressure of 160 to 180, 179 systolic and 100 to 109 diastolic, requires a fewer visit and with a shorter interval, and the stage 1 depends upon more guideline. This guideline also supports the use of out of office blood pressure measurement, that is home blood pressure monitoring and ambulatory blood pressure monitoring, as an alternate strategy to repeat office blood pressure measurement to confirm the diagnosis of hypertension. That if there is any controversy, then ambulatory or office blood pressure or home blood pressure monitoring should be done. There is a special condition I mentioned, blood pressure during exercise and high altitude. It is important to recognize that blood pressure increases during dynamic and during dynamic exercise, and that increases more pronounced systolic and blood pressure both. And evidence shows that blood pressure increases at high altitude exposure, especially above 3000 meters and possibly above 2000 meters. It is important that uncontrolled severe hypertensive patient or grade 3 hypertensive patient should avoid exposure at a very high altitude, and grade 2 and grade 1 hypertension blood pressure should be controlled, and they should go to a high altitude of greater than 2500 meter exposure. This is the patient evaluation of a patient with hypertension. Risk factors should be evaluated if the patient had history of cerebrovascular disease, stroke, renal disease, or the patient has history of smoking, salt intake, alcohol consumption, and if sedentary lifestyle. There is sleep history, snoring. Sleep apnea is an important risk factor nowadays for hypertension, and previous hypertension in pregnancy and preeclampsia. History of symptoms of hypertension mediated organ damage should be identified. Brain and eye involvement, that is TIA, whether there is any history of TIA or stroke or carotid revascularization. There's a carotid artery should be heard of for carotid bruit, for chest pain, shortness of breath, whether the patient has history of coronary artery disease or history of coronary revascularization, history of arrhythmias and heart failure. Kidney may be involved, and it may be evaluated by hematuria, nocturia, repeated urinary tract infection. Peripheral vascular disease is an important features of hypertension mediated organ damage. Cold extremity, intermittent claudication may be present, and family history of polycystic kidney disease should be evaluated. This is the, I already mentioned this one. Symptoms of hypertension is variable. In most of the books or guidelines, it is written that hypertension may not produce any symptoms. Headache, hypertension may produce headache, and it may produce confusion or fatigue, which may be due to hypertensive encephalopathy. Vision problem due to retinopathy. Hypertension is an important risk factor for coronary artery disease, which may produce chest pain. Hypertension is an important cause of LVF. Hypertension causes left atrial enlargement, give rise to atrial fibrillation and other ectopics. Hypertension may produce blood in urine. The common symptoms of pounding of chest and neck and ears may be found in patients with hypertension, that is warming of the neck, chest and ears is an important symptoms of hypertension. These are the key steps for physical examination. I have already measured. I have already said some words about this. So these are the important, some important physical sign for hypertension. Next is the when we should screen for secondary hypertension. We should think of secondary hypertension. We should think of secondary hypertension when there is drug resistance, abrupt onset of hypertension. There was no hypertension, suddenly blood pressure developed. Onset of hypertension less than 30 years. In many books, it is now 25 years. Exaggerated or previously controlled hypertension now become uncontrolled. There is target organ damage or hypertension mediated organ damage or unprovoked or excessive hypokalemia. These are the routine investigation. You all know this. This is a common slide. You should do an CBC, do an blood glucose level, glycosylated or glycosylated hemoglobin, fasting blood sugar, fasting lipid profile, sodium and potassium, important risk factor for hypertension, uric acid level, EGFR should be maintained, liver function test, and then 12-lead ECC, and then urine analysis. This should become almost in the beginning. This should be done. From this urine analysis, we may get very much information about the microscopic status, about the renal involvement, about diabetes. Now the complication of hypertension. Complication of hypertension is hypertension mediated organ damage refers to structural or functional changes in arteries or end organs, that is heart, blood vessel, brain, eyes and kidneys, caused by elevated blood pressure and is a marker of preclinical or asymptomatic cerebrovascular disease. Hypertension mediated organ damage is common in severe or long-standing hypertension, but can be found in less severe hypertension. With wider use of imaging technique, hypertension mediated organ damage is becoming increasingly apparent in asymptomatic patients. Cardiovascular risk increases with the presence of HMOD, and more so when damage affects multiple organs. Some type of HMOD can be reversed with antihypertensive treatment, especially when they are used early during the long-standing hypertension. HMOD may become irreversible despite improved blood pressure control. This is a slide, almost the last slide of the some special investigation other than ECG and albumin creatinine ratio, giving features of renal damage, blood creatinine level, echo to show the cardiac evaluation, carotid Doppler study, and abdominal ultrasound to evaluate aortic aneurysm, to adenoma of the adrenal glands, and then ankle brachial ratio to see the lower limb extremity feature, cognitive sign of doing an MRI, and brain imaging can be done. With this, when a patient of hypertension should be referred to an hospital-based care, because hypertension is well managed at an outdoor basis or in house. The following condition needed to referral to a routine hospital-based evaluation. Patient in whom secondary hypertension is suspected, younger patient less than 40 years with grade 2 severe hypertension, in whom hypertension cannot be excluded or controlled, patients with a treatment-resistant hypertension, patient in whom more detailed assessment of hypertension-mediated organ damage should influence treatment. Patient with sudden onset of hypertension when blood pressure has previously been normal. With this, I conclude. Thank you all for patience hearing.
Thank you, Dhiman, for a very elaborate and detailed discussion of hypertension. Actually, hypertension is such a subject that the more we go into it, the more questions we want to find answers to. So thank you for that. And actually, we are running a bit late tonight, but the evening is growing. So I would first request our experts, if they have any questions or queries or comments, to make them. So do we have Professor Shafi Majumdar with us? Maybe because he's got another session, I think, so maybe he's already left. If not, I would be very grateful if Professor Lutfur Rahman would be kind enough to make any comments here, or what would be an important point for our students to remember from this discussion.
Thank you,
Professor Lutfur Rahman.
Thank you, Professor Dr.S.M. Rahiduzzaman. Dr. Dhiman, you have mentioned all the corner of the hypertension related to diagnosis, clinical feature and complications. Very nice lecture, elaborate lecture. So I give you thanks. But one thing, what is hypertensive emergency and urgency? In the examination, usually it is invariably asked to the students about hypertensive crisis. That is hypertension, urgency and emergency. What is the difference, and what are the treatment difference? Students are invariably asked in this.
I think, sir, the next speakers will be dealing with these one by one. So we have
there is a special circumstance.
Yes, so
okay, thank you.
Yes, so Dr. Ashok Datta,
nice presentation. Both of them presented their lecture very nicely, elaborately.
Thank you, sir.
Excellent
so
presentation.
Now we will move on to our third speaker, who will be talking about management, and our last speaker is Dr. Ishraquzzaman, who will be talking about special situations, and I believe that he will be covering hypertensive emergencies and other aspects of hypertension.
Other aspects. Okay,
Yes,
thank you. Thank you.
So now Dr. Ashok Datta will be telling us how to manage our patients. Dr. Ashok Datta.
So my screen is visible, ma'am?
We can see your screen, yes.
Yes. Thank you, ma'am. Respected teachers, my dear colleague, and all the participants, good evening. My topic is management of hypertension. Actually, the diagnosis of hypertension is the toughest thing that we many times we face. Management is relatively easier. Treatment of hypertension includes lifestyle modification, drug treatment, and there is newer approach of treatment of hypertension is percutaneous intervention on is renal denervation, carotid baroreceptor activation, therapy. These two are especially important for resistant cases of hypertension. Like Dhimanda, I want to start with a very short story that I presented about 8 years back. 60 years old man from Maulovi Bazar, 2 sons staying in UK, admitted in specialized corporate hospital with stroke right-sided hemoptysis. His son demanded for best possible treatment and best medication, and he was treated accordingly with best medication as per guideline as well, but all are costly. That time Lescol was available, Covaram also available, clopidogrel, insulin, Jardiance, that time it was available also. And monthly cost was about 10,000 taka per month. And the other patient with similar history was getting aspirin, atorvastatin, enalapril. Sometimes it was a very popular, till now it is a very good drug, metformin, gliclazide. And he's taking medication regularly with cost around 500 per month. And for last 10 years, he was doing well. But first man who came from Maulovi Bazar, they presented in our ER with acute STEM, LVF, because he stopped medication, not because of monetary problem, because of unavailability of the drug in that area. That time it was actually national, some hotel was like this. So the important thing is cost, availability of the cost, availability, convenient dosing, side effect of the treatment, that should be kept in consideration always before prescribing antihypertensive drugs. So this is the closer for initiation of treatment of hypertension. Ideally, single pill should be started, and if to reduce the side effects, sometimes dual low dose combination should be started. Usually, S inhibitor and calcium channel blocker. S inhibitor is a good drug, especially for younger group is less than 60, and calcium channel blocker in elderly people. In stage 2, dual full dose combination of higher dose of, means optimal dose of S inhibitor and optimal dose of S inhibitor and optimal dose of calcium channel blocker. Step 3 is triple drug combination that includes the diuretics. Sometimes diuretic may be used in the step 2 in combination with S inhibitor. And step 4 is the resistant cases of hypertension, where maximal dose of triple drug, at least diuretic should be there, fails to control the blood pressure. In that case, a special situation, that is spironolactone, centrally acting drugs, direct vasodilator, that may be useful. So, office systolic blood pressure treatment target range. This is taken from the SCC AHA guideline, and as per ISA, means International Society of Hypertension, target blood pressure is 10 millimeter higher than SCC guideline. Age 18 to 65, target blood pressure should be 130 systolic and diastolic 80 or less than 80. But according to ISA, it should be 140 below 90. And age more than 65, blood pressure control a bit, especially systolic blood pressure control, may be a bit relaxed. And for diastolic blood pressure, it should be less than 80 millimeter and should never be below 70 millimeters. Sometimes in elderly people, systolic blood pressure is very high, diastolic is 70, 65 like this. In that case, it is difficult to control the systolic blood pressure without reducing the diastolic blood pressure, because lower diastolic blood pressure less than 70 increase the cardiovascular risk. And first is the lifestyle modification for the management of hypertension. Weight reduction is very much important aspect, especially to maintain the normal body weight with BMI below 25. It reduces the blood pressure about 5 to 20 millimeter mercury. Then dash diet. Sometimes it is asked in the exam, what is dash diet? Dash means dietary approach to also consumption of diet-rich in fruits, vegetables, low-fat dairy product with reduced content of saturated and total fat. That can reduce the blood pressure around 10 millimeter. Dietary sodium restriction to 6 gram of sodium chloride, that is equivalent to 2.4 gram of sodium, that can reduce around 5 millimeter blood pressure. Physical activity definitively that can reduce the blood pressure, and moderation of alcohol consumption. Next, drug that used commonly, A, B, C, D, and E. A is the ACE inhibitor and ARB, and there is some direct renin inhibitor like aliskiren. B is the beta blocker. Now it is the second choice, but not the first choice of drug, except in special circumstances, calcium channel blocker, diuretics, and etc. Etc. includes alpha blocker, prazosin, trazodone, and doxazine. Prazosin are now used especially in case of CKD cases where the hypertension is resistant. This is a good option, but postural hypertension is very common, especially with first or second dose. Centrally acting drug like clonidine, nowadays it is available in the name of cataphrase. It's useful in case of panic disorder, postmenopausal syndrome, anxiety, and methyldopa, that is very common drug, especially used in pregnancy. And direct vasodilator like hydralazine minoxidil, this is hydralazine useful in IV preparation for control of hypertensive emergency. Now, ACE inhibitor, all the ACE inhibitor ends with pril. Side effect of ACE inhibitor and mechanism of ACE inhibitor, how it acts, every student should know. Common side effects is the dry cough that may be up to 30%, but less than 10% may need discontinuation of ACE therapy. Sometimes dry cough may appear after several months or years with other aggravating factors that may produce cough. Angioedema is other side effect. Postural hypertension, once we are very much afraid to give the ACE inhibitor, after hospitalization we use it. Especially that is important when the patient is on diuretics, patient has got sodium or hyponatremia. And hyperkalemia is the side effect, especially when it used with patient renal failure. One is captopril, enalapril, these are two are relatively short acting. Captopril is the shortest acting. It should be given 3 times a dose. And these short acting are especially suitable in hospitalized patient for uncontrolled hypertension and patient with heart failure. And then we can switch over to the long-acting drugs. Enalapril is a very cheap drug and effective drug, but should be given at least once daily or daily dose. Lisinopril, ramipril, and perindopril, these are the relatively long-acting drugs. All are available. And these drugs has got wide range of utility other than hypertension also. These drugs may be used alone or in combination with hydrochlorothiazide or in combination with thiazide-like diuretics like indapamide. Perindopril is also available in combination with amlodipine. Benazepril is a very useful and low-cost drug. Once it was available with amlodipine combination, now it is less available, but till now it is available in market. ARP all ends with, ends with sartan. That is the losartan, candesartan, valsartan, irbesartan, telmisartan, and olmesartan, and azilsartan also. So telmisartan and olmesartan are the longest acting ARB, and it may be available in combination with thiazide diuretics and amlodipine preparation. And valsartan is a drug that has got relatively short acting, should be used BD dose, especially helpful in heart failure patient, and that Vellard and Valiant study prove it. Now, beta blocker, though it is a second-line drug, but sometimes it is useful. Along beta blocker, especially in patients with heart failure, patients with arrhythmia, and those who have got established coronary artery disease. In absence of established coronary artery disease, role of beta blocker is not so much beneficial. Propranolol, metoprolol, atenolol. Out of these 3, something all the students should remember. Propranolol is the highest lipid soluble. So it can cross the blood-brain barrier, it can cross the placental barrier. Atenolol is the second most important drug that can penetrate the blood-brain barrier and placenta and subsequently metoprolol. So this three drug has got CNS activity, especially in anxiety patients. And these three drugs should not be used, better to avoid in case of, should not be used in pregnancy, but metoprolol sometimes it is advocated as it is less, crosses less through the placenta. At the same time, this drug should not be used in lactating mothers because secretion in the milk is larger amount that can affect the baby. Bisoprolol, sotalol, actually this is more anti-arrhythmic than antihypertensive. Nebivolol is selective beta blocker. Carbidopa has got alpha and beta blocking effect. Sometimes alpha and beta receptor antagonist effect is 1:1, and the labetalol has got alpha blocking effect 5 times than the beta blocker. So labetalol is used in pregnancy and IV preparation that is available in our country, IV preparation in emergency situation, in eclampsia, in pregnancy also. So this is mainly the alpha blocker, and carbidopa is both alpha and beta blocker, and all other mainly the beta blocker. And there are some selective beta blockers like bisoprolol, like nebivolol, but all the beta blockers that are selective at low dose, at higher dose, that becomes non-selective. That means that may produce other beta receptor blocking, produce bronchospasm as well. So I have already told regarding in other than ISD, LP dysfunction, heart failure, arrhythmia, and established coronary artery disease, use of beta blocker is controversial for hypertension. But when the patient has got tachycardia, then it is a very useful drug. Calcium channel blocker is a very friendly drug. Amlodipine, nifedipine is the older drug. Latadipine, cilnidipine, and lasitipine. Nimodipine is especially useful for subarachnoid hemorrhage. And this diltiazem and verapamil is non-dihydropyridine. Among this non-dihydropyridine, diltiazem is mainly anti-ischemic effect than antihypertensive effect, and verapamil has got more antiarrhythmic than antihypertensive effect. This is a very friendly drug, metabolically neutral, that does not produce electrolyte imbalance, can be used diabetes without any fear of diabetic deterioration. CKD patient, this is also friendly, and it reduces the cerebrovascular mortality. Non-dihydropyridine, diltiazem and verapamil is contraindicated in patient with heart failure and bradycardia. But amlodipine and other hydropyridine groups may be used if the blood pressure cannot be controlled with ACE inhibitor, diuretics, and ejection fraction is more than 40%. Ankle edema, sometimes this is asked in the exam, why ankle edema happens, because calcium channel blocker is the vasodilator, mainly the arterial dilator. And if arterioles are dilated, venous system is not dilated, then all the blood will be accumulated in the arterioles and capillary, and that will not go back to the right atrium through the venous system, as the venous system is not dilated in conjunction with the arterial system. But so why dependent on leg edema happens in case of calcium channel blocker? But it is less common with this three group of drugs: cilnidipine, lasitipine, and latadipine. But in ACE inhibitor ARB, why they are also the vasodilator, but ankle edema, that sometimes called amyloedema, does not happen because that produces the arterial dilatation as well as venous dilatation. Gum hyperplasia happens with any one of these drugs. Sometimes palpitation because of tachycardia, flashing, and headache may be the side effect of amlodipine and nifedipine. So diuretics. Diuretics in the newer guideline, thiazide type of diuretics, including chlorothiazide, hydrochlorothiazide, and benzochlorothiazide, is mentioned as an indication, but in the older guideline, only thiazide-like diuretics was included, not the thiazide diuretics. But this is for the long time. This is used as an antihypertensive drug in combination with ACE inhibitor and others. And thiazide-like diuretics is more preferable, but cost is an issue like chlorthalidone, indapamide, and metolazide. Potassium sparing diuretics sometimes useful in resistant hypertension. Other two drugs, amyloid and triamterene. What Rahiduzzaman sir was telling, these are very potent drugs. Both amyloid means amyloid plus hydrochlorothiazide and triamterene with hydrochlorothiazide. Very cheap drug, but it is less available. Very cheap, but less available. But the side effect is hypokalemia is less likely because there is potassium sparing as well as thiazide. But hyponatremia may happen with this drug. And other side effect is new onset of diabetes. This happens with this thiazide group of diuretics. And good evidence of cardiovascular benefit from higher dose or moderate dose of thiazide diuretic, but not with the low dose of thiazide diuretics, as well as chlorthalidone and indapamide. Drug of choice. How do we choose a drug? Some tips. Like patient with anxiety, if we start from above, from brain, anxiety neurosis, beta blocker, especially in younger. Psychiatric illness, suppose patient is getting the SRI, means serotonin reuptake inhibitor like sertraline or amlodipine like this, that may produce tachycardia. And sometimes that may produce vasodilation, postural hypertension. Better to avoid ACE inhibitor with this group of drugs. So beta blocker is a good choice if the patient is on this type of drugs. Bronchial asthma and COPD. If any patient having severe attack of COPD or asthma, better to avoid beta blocker, even selective one. But those who have got mild symptom, this can be used. In patient with heart block, means AB block, 6 sinus symptom or sinus bradycardia, beta blocker or verapamil detergent should be used very cautiously. But in presence of LVB or RVB, especially LVB, RVB, this is intrahepatic. At this level, beta blocker or verapamil or don't have any effect. That is, this bundle branch are not supplied with the sympathetic supply. So LVB or RBB is not contraindication of any verapamil, diltiazem or beta blocker, provided AB node is good, bundle of is good. For heart failure, definitively beta blocker, ACE inhibitor, diabetes. Three drugs are very important. Sometimes it happens in acute MI setting. Suppose patient with CCU acute MI setting, which one you should start. If the patient is hypertensive, definitively beta blocker is the first choice to reduce arrhythmia and certain death after MI. But if the patient is in severe failure, beta blocker should be avoided initially till the patient's blood pressure, heart failure is not controlled with diuretics ACE inhibitor. So ACE inhibitor is the choice of drug for failure. Beta blocker is choice of drug for arrhythmia. Diabetes mellitus ACE inhibitor ARB prevents the renal and retinal complication of diabetes mellitus. So this is a compelling indication in diabetic patient as an antihypertensive drug. For goutic patient, thiazide diuretics should be avoided. Sometimes losartan may reduce the serum uric level. Diuretics is contraindicated if any patient have got severe electrolyte imbalance like hyponatremia, hypokalemia. Kidney stones, probably thiazide diuretics has got positive effect that reduce the renal stone. Actually, that absorbs the calcium as well. So that is also helpful in elderly people, reduce the osteoporosis. And in case of benign prostatic hyperplasia, alpha blocker like prazosin, alpha press is helpful for antihypertensive as well as prostatic hyperplasia prevention. But hypertension, postural hypertension is a side effect for elderly people. For pregnancy, I think Dr. Ishaq will talk about it in details. Alpha-methyl dopa, labetalol, and calcium channel blocker is the choice of drug. Metoprolol may be acceptable. Pregnancy with urgency, IV labetalol, hydrolyzine, nitroprusside should be avoided because that may produce fetal cyanide poisoning. And magnesium in eclampsia. For lactating mother, I have already told propranolol, atenolol, lipid soluble processed blood barrier should not be used, like nifedipine also. Alpha-methyl dopa should be discontinued immediately after delivery if it is used in pregnancy because that may produce psychosis and because that require frequent dosing, 2 or 3 times dosing. Drug choice. Overall benefit of treatment depends on how perfectly optimal blood pressure is achieved, with or without or with minimal side effect. Possibly class-specific benefit includes CCB protective effect versus heart failure, CCB and ARB more protective in case of stroke, compelling indication for a specific condition. I will tell you it sometime. Next slide. Use of once daily dose is very important, and wait for 5 to 7 days to get the optimal drug effect, and allow 4 weeks to evaluate or change the drug, and titrate to manufacturer's instruction. When all else are equal, use the least expensive drug. If no cost disadvantage, encourage this dose combination. This dose combination has got some additive effects, sometimes synergistic effects, like diuretics with ACE inhibitor ARB. That can reduce the side effect by use of less dose of drug or both drugs. Enhance the convenience and compliance, prolong the duration of action, and potential for additive target organ protection. So this is the compelling indication in heart failure, diuretics, beta blocker, ACE inhibitor, ARB. All are compelling indication if the patient is hypertensive, as well as aldosterone antagonist. Post-MI patient, beta blocker, ACE inhibitor. High coronary risks already established, then beta blocker is an indication to reduce the heart rate, to reduce the coronary events, to reduce the arrhythmic death. Diabetic patient, ACE inhibitor, ARB. Kidney disease patient, control of blood pressure is effective. For kidney disease, if the patient has proteinuria, then ACE inhibitor, ARB is a good choice of drug, and target should be 140 over 90 or below. But if the patient has got proteinuria, target should be 130 or below. In systolic blood pressure, 80 or below. But in absence of proteinuria, target blood pressure should be 140 over 90 or less. And ARB and ACE inhibitor sometimes asked once it was popular that both combination of ACE inhibitor ARB in case of kidney disease. But now it is discouraged. Why it is discouraged? Maybe asked in exam, because combination has shown that some of the patient goes into acute kidney injury. So this combination of ARB and ACE inhibitor should not be used in kidney patient or any other patient. Recurrent stroke, ACE inhibitor, ARB, diuretics are useful. Which combination? This is a very old diagram. Calcium channel blocker has got combination with beta blocker, diuretics, ACE inhibitor or ARB. So any combination is available. All the combinations are available in our market. So hypertensive emergency, ischemic stroke, hemorrhagic stroke, encephalopathy, eclampsia, acute coronary syndrome, left ventricular failure, and aortic dissection. Dr. Ishaq will talk about it. And management of special situation. I think Ishaq will cover it. I will not go in details. Now, I'm in conclusion. Primary prevention is the prime important, followed by early detection and treatment of hypertension. And drug therapy, though it is the most costly and popular way to control, it is not only the solution. So with this, I like to thank for patient hearing.
Thank you, Ashok. That was really comprehensive, and we all learned such a lot. Really great presentation. Enjoyed it a lot. And I would request our expert to give his comments. Professor Lutfur-Rahman, please, sir.
Lutfur, sir.
Nice presentation, Ashok Datta. You have presented very nicely, elaborately. So we can go to the next speaker, I think.
Okay. Right, sir. So our last speaker is Dr. Rahiduzzaman, and he has a difficult task because he will be talking about different special situations in hypertension, and there are so many special situations and emergencies. So without further ado, Dr. Rahiduzzaman.
Thank you, madam. Respected moderator, expert panelists, teachers, colleagues, and attendees, Assalamu alaikum. So I'm Dr. Rahiduzzaman, going to present topic on hypertension in spatial situation. Most often we find patients with uncontrolled elevated blood pressures in outpatient department or emergency department. Then the question arises whether to admit this patient or whether to start IV antihypertensive drug or just discharge the patient with oral antihypertensive. So presence of acute hypertension mediated organ dysfunction, which was covered by Dr. Dhiman Bonik. So presence of this acute HMOD actually determine whether we should admit the patient or not. So hypertensive emergency defined as severe hypertension, which is associated with acute hypertension mediated organ dysfunction, which is often life-threatening and requires immediate but careful intervention to lower blood pressure, usually with intravenous therapy. On the other hand, hypertensive urgency, patient might have severe hypertension, but if the patient doesn't have any acute hypertension mediated organ dysfunction, so we can easily discharge the patient and the blood pressure can be lowered over a period of days to weeks with oral medication. The underlying pathophysiology of hypertensive emergency is loss of autoregulation, and which causes abrupt elevated level of vasoconstrictor, causing the increased systemic vascular response, resistance, and elevated blood pressure. And eventually, fibrinoid necrosis occurs in the endothelium, and further, this necrotic debris accumulates and obliterates lumens of the vascular arterioles and causes end organ ischemia. And when the tissue organ ischemia occurs, it releases more vasoactive substances, so initiating the vicious cycle of elevated blood pressure. So just to recapitulate the autoregulatory mechanism, which functions normally in range of mean arterial pressure from 60 to 120 millimeter of mercury in normotensive patients or inadequately controlled hypertensive patients. On the other hand, chronically hypertensive patients, this range shifts to right. So arteriolar smooth muscles hypertrophy allows tissue tolerance of higher blood pressure. So in these patients, rapid reductions of blood pressure results in tissue hypoperfusion and ischemia. So considering the normal range of MAP or mean arterial pressure in the normotensive patients, many patients may develop hypertensive emergency when the pressure is more than 160 over 100. There are many clinical presentations of hypertensive emergency, most malignant accelerated hypertensions, which is characterized by severe hypertensions, commonly more than 220 over 120 millimeter of mercury, with advanced bilateral retinopathy, usually flame hemorrhage and or papilledema. But in these patients, also there may be hypertensive encephalopathy or hypertensive thrombotic microangiopathy. Hypertensive encephalopathy is the presence of somnolence, lethargy, tonic-clonic seizures, and cortical blindness, which may precede a loss of consciousness. However, focal neurological lesions are rare and should raise a suspicion of stroke. Patients with severe hypertension associated with other clinical conditions who are likely to require an urgent reduction of BP, for example, acute aortic dissections, acute myocardial ischemia, or acute heart failure. Patients with sudden severe hypertension due to pheochromocytoma, also associated with organ damage, and pregnant women with severe hypertension or preeclampsia, which I will discuss later. Most of the patients have precipitants, and these are the most common is non-adherence to medical treatment. And also there is history of inadequate treatment of chronic hypertension. Male gender, black race, low socioeconomic status, obesity, smoking are the risk factors. And these patients also have might have these pre-existing conditions like renal parenchymal disease, renal artery stenosis, collagen vascular disease, and scleroderma, pheochromocytoma, vasculitis, preeclampsia, obstructive sleep apnea. In the history, we can also find that some medications and illicit drugs like NSAIDs, oral contraceptive pills, ephedrine, cyclosporine, cocaine, and amphetamines. So for the diagnostic evaluation, the meticulous history and targeted physical examination is required, and the bedside fundoscopic examination will give us a findings of exudate, flame shape, hemorrhage, and papilledema in the fundus. And urine analysis will give us a clue of proteinuria, hematuria, and CAF, which indicates a kidney involvement. And other investigations should be done to exclude the other secondary cause of hypertension and also the target organ damage. So all the patients with hypertensive emergency should be admitted in ICU, and the presence of acute or rapidly progressive end organ damage is actually determines whether the situation is an emergency or an urgency. So patients with hypertensive urgency can be treated with oral medication and at home. And the hypertensive emergency patient, they should be admitted in the ICU with the administration of IV antihypertensive. The goal of therapy is to immediate but controlled reduction of mean arterial pressure. Blood pressure be reduced initially by no more than 25% of mean arterial pressure over minutes to hours. After first 24 hours, further reductions over day to weeks in order to reset autoregulatory mechanism. There are exceptions like aortic dissections, pulmonary edema, and postoperative bleeding. So here are some examples, some clinical situations where immediate blood pressure reduction is required. So in case of malignant hypertension with or without acute renal failure, reductions of the mean arterial pressure by 20 to 25% over several hours. The first line treatment is labetalol and nicardipine, and the alternative treatment is nitroprusside and urapidil. In case of hypertensive encephalopathy, they immediately reduce mean arterial pressure by 20 to 25%. The labetalol or nicardipine is a drug of choice, and nitroprusside is alternative. In acute coronary event, systolic blood pressure should be immediately reduced to less than 140 millimeter of mercury. Here is the drug of choice is nitroglycerin. Labetalol can also be used, and urapidil is the alternative choice. In acute cardiogenic pulmonary edema, with the help of nitroprusside or nitroglycerin and with diuretics, the immediate reductions of systolic blood pressure to less than 140 millimeter of mercury is required. And urapidil can also be used. In acute aortic dissections, not only systolic blood pressure, but heart rate should also be lowered to less than 60 beats per minute, and systolic blood pressure to less than 120 millimeter of mercury. Esmolol and the nitroprusside or nitroglycerin or nicardipine can be used here, and the labetalol or metoprolol is alternative. In eclampsia and severe preeclampsia, the immediately reduction of systolic blood pressure to less than 160 and diastolic blood pressure to less than 105, the labetalol or nicardipine and magnesium sulfate usually used, and delivery is considered the curative approach. So there are lots of antihypertensive IV drugs, but in our country, we actually use nitroglycerin, nitroprusside, labetalol, metoprolol, phentylamine, hydralazine. So if to see this algorithm, as I have already discussed, that when a patient comes to us with elevated blood pressure like more than 180 over 120 millimeter of mercury, we need to find whether the patient has target organ damage or not. If the patient has target organ damage, this patient definitely needs to be admitted with the diagnosis of hypertensive emergency, and he should be admitted to ICU, and the conditions like aortic dissections, severe preeclampsia or eclampsia, pheochromocytoma crisis should be excluded. And if these conditions are present, then the systolic blood pressure should be reduced to less than 140 millimeter of mercury during first hour, and then to less than 120 millimeter of mercury in aortic dissections. If these conditions are not there, then the blood pressure reductions by maximum 25% over first hour, and then to 160 by 100 to 110 millimeter of mercury over next 2 to 6 hours, then to normal over next 24 to 48 hours. So if untreated, the prognosis of a patient with hypertensive crisis is very poor. In modern era, with effective antihypertensive drugs, the 10-year survival is around 70%. However, patients presenting with hypertensive crisis have for future cardiovascular events despite a lower prevalence of overall cardiac risk factors. So now hypertensive disorders in pregnancy. Hypertensive disorders in pregnancy affect 5 to 10% of pregnancy worldwide, and this remain a major cause of maternal, fetal, and neonatal morbidity and mortality. Maternal risks include placental abruptions, stroke, multiple organ failure, and disseminated intravascular coagulation. The fetus is at high risk of intrauterine growth retardation, intrauterine growth retardation, like 25% of cases, prematurity, 27% of cases of preeclampsia, and intrauterine death, 4% of cases of preeclampsia. So definition and classification of hypertension in pregnancy. The definition is based on office blood pressure value, with systolic blood pressure value more than 140 millimeter of mercury, and diastolic blood pressure 90 or more millimeter of mercury, and is classified as mild and severe. In case of mild, it is 140 to 159 over 90 to 109 millimeter of mercury, and severe is 160 or more over 110 or more millimeter of mercury. Hypertension in pregnancy is not a single entity, but comprises pre-existing hypertension or chronic hypertension, gestational hypertension, pre-existing hypertension plus superimposed gestational hypertension with proteinuria, preeclampsia-eclampsia spectrum, HELLP syndrome, antenatally unclassifiable hypertension. So pre-existing hypertension precedes pregnancy or develops before 20 weeks of gestation, and usually persists for more than 6 weeks postpartum and may be associated with proteinuria. Gestational hypertension develops after 20 weeks of gestation and usually resolves within 6 weeks postpartum. Antenatally unclassifiable hypertension, this term is used when blood pressure is first recorded after 20 weeks of gestation and it is unclear if hypertension was pre-existing. Reassessment 6 weeks postpartum will help distinguish pre-existing from gestational hypertension. Preeclampsia and eclampsia spectrum. Gestational hypertension with significant proteinuria is preeclampsia, and it occurs more frequently during the first pregnancy, in multiple pregnancy, in high-density form more in antiphospholipid syndrome, or with pre-existing hypertension, renal disease, or diabetes. It is often associated with fetal growth restriction due to placental insufficiency and is a common cause of prematurity. Eclampsia is the development of Cranmer seizures in women with preeclampsia. As proteinuria may be a late manifestation of preeclampsia, it should be suspected when de novo hypertension is accompanied by a headache, visual disturbances, abdominal pain, or abnormal laboratory tests, specifically low platelets and/or abnormal liver function, thus HELLP syndrome. The only cure for preeclampsia is to conduct delivery. So investigations that should be done in pregnant hypertensive women are urine analysis. So all pregnant women should be assessed for proteinuria in early pregnancy to detect pre-existing renal disease, and in the second half of pregnancy to screen for preeclampsia. A district test of 1 or more plus should prompt evaluation of albumin-creatine ratio in a single spot urine sample, and a value of less than 30 milligrams per millimole can reliably rule out proteinuria in pregnancy. Among the other investigations, blood count, hematocrit, liver enzymes, serum creatinine, and serum uric should be done. It should be noted here, hyperuricemia identifies women are at increased risk of adverse maternal and fetal outcomes. Other investigations like ultrasound investigations of the kidneys and adrenals should be done. Plasma or urinary fractionated metanephrosis will exclude pheochromocytoma. Doppler ultrasound of uterine arteries performed after 20 weeks of gestation to detect those at higher risk of gestational hypertension, preeclampsia, and intrauterine growth retardation. A soluble FMS like tyrosine kinase 1 to placental growth factor ratio of less than 38 can be used to exclude the development of preeclampsia in the next week when suspected clinically. These are the women who needs actual prevention of preeclampsia. The high risk of preeclampsia are hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease such as systemic lupus erythematosus, or antiphospholipid syndrome, type 1 or type 2 diabetes, chronic hypertension. And the moderate risk factors of preeclampsia are first pregnancy, age 40 or more years, and pregnancy interval of more than 10 years, BMI of more than 35 kilograms per meter square at first visit, family history of preeclampsia, and multiple pregnancies. These women should be advised to take 100 to 150 milligrams of aspirin daily from weeks 12 to 36. So treatment. So mild hypertension of pregnancy, in case of mild hypertension of pregnancy, the European guidelines have recommended initiating drug treatment in all women with persistent elevation of blood pressure more than 150 over 95 millimeter of mercury. In women with gestational hypertension, with or without proteinuria, pre-existing hypertension with the superimposition of gestational hypertension, or hypertension with subclinical hypertension-mediated organ dysfunction when blood pressure is more than 140 over 90 millimeter of mercury. Considering the drugs, ACE inhibitors, ARB, and direct renin inhibitors are contraindicated. Methyl dopalabetalol and CCBs are the drugs of choice. Already Dr. Ashok Kumar already discussed about it, but just to mention that diuretic therapy is generally avoided because plasma volume is reduced in women who develop preeclampsia, and beta blockers may induce fetal bradycardia. The target of blood pressure is less than 140 over 90. In case of severe hypertension, all the women with systolic blood pressure 170 or more or diastolic blood pressure 110 or more should be admitted in hospital. The selection of the antihypertensive drug and its route of administration depend on the expected time of delivery. Pharmacological treatment with IV labetalol, oral methyl dopa, or calcium channel blocker should be initiated. Intravenous hydroxyzine is no longer the drug of choice. In hypertensive crisis, like in patients with eclampsia or severe preeclampsia with or without HELLP syndrome, hospitalization and BP-lowering therapy is essential, and delivery needs to be considered after the maternal condition has stabilized. Intravenous magnesium sulfate is recommended for the prevention of seizures and eclampsia, and the consensus is to lower blood pressure to less than 160 over 105 millimeter to prevent acute hypertensive complication in the mother. Both labetalol and nicardipine have shown to be safe. The drug of choice when preeclampsia is associated with pulmonary edema is nitroglycerin. In postpartum women who who has blood pressure, it's common in the first week, and methyl depot should be avoided because of the risk of postpartum depression and psychosis. And all antihypertensive drugs taken by nursing mother are excreted into breast milk. So most are present at very low concentration except for propranolol and nifedipine. So with breast milk concentration similar to those in maternal plasma. So these drugs should be avoided. So women experiencing hypertension in their first pregnancy are at increased risk in a subsequent pregnancy. Women who develop gestational hypertension or preeclampsia are at increased risk of hypertension, stroke, and ischemic heart disease in later adult life. Annual visits to a primary care physician to check blood pressure and metabolic factors are recommended for these patients. Now the resistance hypertension, which is defined as resistant to treatment when the recommended treatment strategy fails to lower office systolic blood pressure and diastolic blood pressure values to less than 140 millimeter of mercury and or less than 90 millimeter of mercury respectively. It should be mentioned here that appropriate recommended treatment strategy means appropriate lifestyle measures and treatment with optional or best optimal and or best tolerated doses of 3 or more drugs, which should include a diuretics with typically an S inhibitor or an ARB and a calcium channel blocker. The inadequate control of blood pressure should be confirmed by ambulatory blood pressure monitoring or home blood pressure monitoring. In whom the adherence to therapy has been confirmed, and pseudo-resistant hypertension and secondary cause of hypertension should also be excluded. The true prevalence of resistant hypertension is less than 10% of treated patients, and patients with resistant hypertension are at higher risk of HMOD, CKD, and premature cardiovascular events. So these are the causes of pseudo-resistant hypertension. The most common is poor adherence to prescribed medicine. So it should be taken in the history that whether the patient is adhering to the medicine or not, because more than 50% of patients give history of non-adherence. White coat phenomena, poor office blood pressure measurement technique, marked brachial artery calcification, especially in older patients with heavily calcified arteries are the other cause, and the clinician inertia when a doctor doesn't want to prescribe rational combination of blood pressure lowering drug therapies. So other causes of resistant hypertension is lifestyle factors such as obesity or large gains in weight, excessive alcohol consumptions, and high sodium intake. Intake of vasopressor or sodium retaining substances, drugs prescribed for conditions other than hypertension like some herbal remedies or recreational drugs used, cocaine, anabolic steroid, etc., etc. So obstructive sleep apnea is another cause of resistant hypertension. Undetected secondary forms of hypertension, advanced hypertension-mediated organ damage, and particularly chronic kidney disease or large artery stiffening are the other cause of resistant hypertension. So these are the clinical characteristics. Most of the patients with resistant hypertension are in older age, obese, more common in Black people, they have history of excess dietary sodium intake, and they have high baseline blood pressure and chronicity of uncontrolled hypertension, and usually they have concomitant disease like left ventricular hypertrophy or chronic kidney disease, diabetes, atherosclerotic vascular disease, aortic stiffening, and isolated systolic hypertension. So diagnostic approach to resistant hypertension is first to take the proper history, including lifestyle characteristics, alcohol and dietary sodium intake, interfering drugs or substances, and sleep history, the nature and dosing of the antihypertensive treatment, and confirmation of the adherence to blood pressure lowering therapy. Physical examination should be targeted to focus the determining the presence of hypertension-mediated organ damage and signs of secondary hypertension. And all the laboratory investigations also is to be done to detect the HMOD and the secondary cause of secondary hypertension. So treatment of resistant hypertension, first we need to reinforce of lifestyle measures and discontinuation of interfering substances, and then the sequential addition of antihypertensive drugs to the initial triple therapy. So ultimately, replacing all current drugs by a simpler treatment regimen using single pill combination treatment is recommended to reduce pill burden and improve adherence to treatment. The addition of low dose spironolactone to existing treatment can be done, or the addition of further diuretic therapy if intolerant to spironolactone with either eplerenone or amiloride, or a higher dose of thiazide or thiazide-like diuretics, or a loop diuretic can also be added, or the addition of bisoprolol or doxazosine. Renal denervation accorded baroreceptor pacing interrupt the sympathetic nerve activity. However, there is not sufficient evidence to recommend the use of this device in managing the resistant hypertension. When a patient comes to us with a elevated blood pressure and the neurologic symptoms, then we have a dilemma whether the patient's got hypertensive encephalopathy or the stroke. So hypertension is a major risk factor for hemorrhagic and ischemic stroke and a risk factor for recurrent stroke. So, but management during the acute phase of hemorrhagic and ischemic stroke remains an area of uncertainty. And neurologic alteration caused by severe hypertension are reversed when blood pressure controlled appropriately in hypertensive encephalopathy, whereas primary neurologic disorders typically do not improve with blood pressure control. And also, focal neurological lesions are rare in case of hypertensive encephalopathy and should raise a suspicion of stroke. So therapeutic strategy, in case of acute intracerebral hemorrhage, immediate blood pressure lowering is not recommended for patients with systolic blood pressure less than 220 millimeter of mercury. And in patients with systolic blood pressure 220 or more millimeter of mercury, careful acute blood pressure lowering with IV therapy to less than 180 millimeter of mercury should be considered, which is class 2A B recommendation. In acute ischemic stroke, routine blood pressure lowering with antihypertensive therapy is not recommended, with the exceptions like in patients with acute ischemic stroke who are eligible for thrombolysis. BP should be carefully lowered and maintained at less than 180 over 105 for at least the first 24 hours after thrombolysis. And in patients with markedly elevated blood pressure who do not receive fibrinolysis, drug therapy may be considered based on clinical judgment to reduce by blood pressure by 15% during the first 24 hours after the stroke onset. In hypertensive patients with an acute cardiocerebrovascular event, antihypertensive treatment is recommended immediately for transient ischemic attack after several days in ischemic stroke. In all hypertensive patients with ischemic stroke or TIA and systolic blood pressure target range of 120 to 130 should be considered. And the recommended antihypertensive drug treatment strategy for stroke prevention is a RAS blocker, ACE inhibitors or ARB, plus a calcium channel blocker or a thiazide-like diuretics. So this is the algorithm that I have already covered. So thanks for the patient sharing. Thank you.
So thank you. I managed to get back. I was lost for a bit. So that was a great presentation and we all learned such a lot. And I see Professor Amol with us. So Amol, do you have any comments?
Thank you, ma'am, for nice arranging. I like to say one thing that why I attend this lecture, because I think most of you, all people will agree with me that the treatment of hypertension is one of the bread and butter for cardiologists. None of the day in chamber, or right now I am sitting in chamber, but I need to manage. So I review. I want yesterday they review this hypertensive treatment by Ashok Datta and Ashrak. Thank you, madam. Very nice presentation, very brilliant. Two peoples, speaker is very nicely present, and in this my personal knowledge. I don't know about others, but thank you, ma'am. Thank you.
Thank you for joining. And you, well, you missed Dr. Dhiman Bonik. He was also very good, and Dr. Kolimuddin equally great. So we actually had a very exhaustive discussion with 4 speakers. And thank you for joining. We really appreciate that you could join us. So we all learned a lot, and I'm sure you also benefited from their lectures. Thank you, Amol. So now I would request our expert, Professor Lutfur Rahman, to have his views on these lectures, please. Professor Lutfur Rahman.
Thank you, madam. Really a very nice academic discussion. I have enjoyed it very much. Thanks to the organizer, honorable moderator, and speakers. A lot of special thanks to the speakers, because all of you have presented your topics very nicely and elaborately with very latest information. I think all of the students will be very much benefited from your lectures. And I have also refreshed my knowledge from your excellent, deliberate, informative deliberation. Thank you very much. Thank you.
Thank you, sir. And I would request Professor Rahiduzzaman to make any final concluding comments. Professor Rahiduzzaman.
Thank you, madam. Actually, nothing more to say. Actually, all the lectures were so elaborative and descriptive, so nothing more to add. And I have personally learned a lot. Only one thing that Professor Lutfur Rahman sir has mentioned about the guideline of International Society of Hypertension. That was the latest one, 2020. They have actually divided hypertension a bit differently than what ESC and AHA have done. But I think that is very close to that what we have discussed here. Anyway, but I think the students should also go through the guideline of International Society of Hypertension 2020, because in examination, the examiner may ask some question from that guideline also. So I think that is one point. And another, as I have discussed very early about the, and Professor Rahiduzzaman madam also repeated the same thing, that guideline is there always, but we should always treat our patient individually. Every patient is unique. So we should think the socioeconomic condition of the patient, the morbidity of the patient, and then we should choose the drug for the patient. Maybe a patient control his blood pressure with simply 50 milligram of atenolol. I have seen a lot of patients simply taking 50 milligram of atenolol and very, very well controlled hypertension. So when this patient is coming to me, why should I change the patient, change the drug? No, let the patient continue with atenolol if there is no contraindication. So I think that's the point we should always take into consideration regarding the patient, treating the patient with hypertension. Thank you. Nothing more to add. Thank you all the speakers and the moderator and the chairperson. Thank you very much.
So thank you. So I think we can conclude this session, and we learned such a lot and great session. Thank you. So we will conclude the session now with the permission of our expert and everyone. So bye. Thank you.
Thank you.